Hello, everybody. My name is Arun Sahai. I'm a consultant urologist at Guy's Hospital in London. And welcome to the ICS webinar, The Future of Urodynamics in Female Overactive Bladder. I'm delighted to tell you that I'm joined today by an amazing, world-renowned faculty who I'm pleased to report are also my dear friends. I will start off with Benoit Peyronnet, who's the professor of urology in Rennes in France. In terms of ICS, is about to launch the ICS Robotic Committee, which will be very exciting. There is an advert that's come out that you should be aware of. So that's very, very exciting news for ICS and those enthusiasts in robotics. And I'd also like to introduce our other co-chair, Eskinder Solomon, who's a consultant clinical scientist who actually works in my unit in Guy's in the Department of Urology, who chairs the ICS Urodynamics Committee. So we're very grateful to you both for coming to join for this important webinar. Today, we're going to have 3 talks, lots of interactive discussions. So we're really hoping that you post your questions in the chat box. At the end of each talk, there'll be a mini discussion, and we're happy to bring your questions in, which we will discuss online. And then there'll be a slightly larger discussion towards the end. Benoit's going to kick off all about overactive bladder, pathophysiology, and the importance of phenotyping. Then Eskinder will come on and talk about the value and utility of urodynamics. I'm then going to come and talk to you about the future trial. Many of you might be aware of this, a very important study that we will discuss. And then we'll summarize at the end. So looking forward to the session. The whole thing will run for about an hour or so. So to kick off, we thought it'd be very interesting if we could launch a poll. We're going to have a very quick poll for the audience. And we're going to ask the same question to you now and hopefully at the end of the webinar, just to see what your thoughts on the subject are. So the question that we pose to you is: urodynamics in women with overactive bladder should be performed either in every patient, in most patients, half the patients, occasionally, or never. So please put your vote in.
Interesting.
Right. So we have a real mix. 27% are suggesting in everyone. I would say 50% in most or half, 23% occasionally, but no one has said never. Very interesting.
So
Okay.
I think it's too easy for us because we have only clever people in the room already. So it's gonna be an easy webinar. Okay. So may I go, Arun?
Yes, please, Benoit.
So thank you so much first to the ICS for inviting me, and to my friend Arun and Solomon and Eskinder to join this webinar. It's I would say they gave me a favor because the topic of the webinar is fantastic, but they gave me the part that I love the most. In France, we say it's the Madeleine de Proust. These things that you have since your childhood and that you love so much and you love to come back to it. So it's all about phenotyping of overactive bladder, which is a concept that I believe very much in. I will try to keep my time because I'm, as always, quite passionate about it. I have conflict of interest, a lot of them, with basically everybody. So they say when you have conflict of interest with everybody, in the end, you don't have conflict of interest. I'm not sure how much it's true, but anyway. So I want to start by reminding us of the definition of overactive bladder, which was put forward and elaborated by the ICS itself in 2002. And so it's urgency with or without incontinence, usually with frequency and nocturia. So it's a purely clinical definition. So basically, any patients who enter your clinic and say, "Oh, I have urgency, frequency," you're an OAB patient, okay? So the issue, of course, this definition has been very beneficial. It has raised awareness among the medical community, among the healthcare authority, and it has promoted the development of many treatment options. Remember that 30 years ago, you had almost only ditropan to treat those patients. Today, you have a whole armamentarium, which is fantastic. So that has been beneficial. But the issue is it has led to those very plumb stepwise treatment algorithm where basically the patient is supposed to undergo every single treatment step by step until finally, maybe if you're lucky, you find the right one. And this approach is, to me, not good for the patients, but it's not even good for the payers. We all lack money. Our healthcare system are in a bad position economically, and we're not doing a good job even economically doing that because we lack money. I would say we spend money using treatments that don't work. And so the whole goal would be to tailor treatment, and that's what we're going to try to prove tonight, and we'll try to see how urodynamic can help for that.
Sorry to interrupt you, Benoit, but I
Yeah.
don't think we can see your slides.
Oh, I'm sorry. Thank you. So as you see, this is the current stepwise approach that I was sort of trying to criticize a little bit, because I don't believe that it's good for the patients, because they have to try all these treatments. And we know, we can go to the next slide if you want, Roger. It's not payer centers. We can go to the next slide. Thank you, really, Eskinder, for having stopped me, because you know me. When I start talking, I will never stop. So I could have done the whole talk without my slides. Anyway, let's move forward. So I was saying it's not even, this algorithm is not even evidence-based, because you have those trial, this trial, especially in the New England Journal of Medicine from the US, comparing anticholinergics versus Botox as a first-line treatment. And not surprisingly, Botox is more effective. So as a patient, I may want to have the most effective treatment first, right? But of course, it's more costly and there are more risks. So you have everything to take into account. We can go to the next slide. And it's not even cost effective. And we have those data, and this is a post-hoc analysis of this ABC trial that I just mentioned, which compare anticholinergic versus Botox, where they showed that after 5 months, the cost effectiveness cross, and Botox becomes most cost-effective than anticholinergics, believe it or not. So we have to rethink the whole process, because it's not patient-centered, it's not payer-centered, and it's not evidence-based. We can go to the next slide. And so another argument that you may want to put forward for this algorithm is to say, oh, let's go with the less invasive first. But you know those data. We have real doubts about the fact that anticholinergics may create long-lasting cognitive dysfunction. So is it really less invasive than having a SNM or a PTNS or whatever else? I'm not sure. We can go to the next slide. And so we know that, again, and then I'll move to something else in the pathophysiology. I promised to talk about the pathophysiology. But we have data showing that we are at the time of patient-centered approach. And the patient, they don't live this stepwise algorithm well. They are exhausted. When you will have tried 15 different medications before, and then 2 invasive treatment before you finally get relieved, it's not good for you. And we have those data from the US showing that only 11% of the patients went to third-line therapy. That's okay. If everybody is relieved, that's okay. The problem is 50% only are well treated at the end of this algorithm. So we have to rethink and change this algorithm. Next slide. And last proof of this is those data about discontinuation of medication. We know that on average, the median time before discontinuation of anticholinergics is 55, 56 days. And we used to say, oh, but it's because of dry mouth and constipation. Beta-3s have much less side effects. And still, the long-term discontinuation is slightly longer, but it's still only basically 6 months. So it's also the fact that it's not effective to every patient. One size does not fit all. We can go to the next slide. And that's where we decided to write this paper with a lot of fantastic legends, I would say, of the field. I felt very humbled to work with those very talented people. In 2019, published in European Urology. Next slide. And the whole principle of this paper was to try to destroy what we had created. We created the term OAB, and then we realized we were not completely right. OAB is not a unique bucket. It's not a disease. I was mentioning Chris Chappell combating me because I used to believe it's a condition, it's a disease. No, it would always tell me it's a syndrome, symptom complex. So very different pathophysiology can give those symptoms. And we have to understand the pathophysiology to tailor the treatment to each patient characteristic. Next slide. So we tried with the existing evidence at that time to describe 11 phenotypes. Certainly there is probably much more than this, or maybe less. It was just an attempt to try to, I would say, deconstruct this idea of OAB. Next slide. And it took me a long time to do this figure, I can tell, because I always tell to my patients, I operate better than I draw. So this one took me a long time. But the whole idea, and I like Pink Floyd, full disclosure, so I was inspired as well. This is the idea of the Prisma approach. You have to forget OAB, and you have to realize that there are different patients, and you want to screen them through clinical interview, physical examination, plus minus diagnostic test, to try to identify the phenotype. And guess what? In those diagnostic tests, there is one that is very important to me in my practice, and it starts with a U and it finishes with dynamic, but I let my friends demonstrate that. Next slide. So of course, there is also just a physical examination. That's just taking time to try to see if there is prolapse, stress incontinence. Those are things that you can depict in clinics. You cannot deal with those patients in 5 minutes. You're not serving them properly. You have to understand what's going on, the pathophysiology. I know the feeling. Most urologists, and I was like this for a long time, would see this OAB patient entering the room, and they would say, oh my God, they are long patients. They are boring. Let's prescribe anticholinergics and let's send them home, and we'll see them one day back, and we'll try to do something else. Next slide. And I will try to keep my time, although I have been delayed a little bit, but it's all my fault. So just inspecting. You have vulvovaginal atrophy. Next slide. Hey, you give vaginal estrogen. We have level 1 evidence showing it works on OAB symptoms. Next slide. And it works even better than ditropans, than anticholinergics. We have a randomized trial showing that the efficacy is equivalent, but you have less side effects. So just examine the patient first, and that will be very helpful. Next slide. Obese patient. I won't go through all the phenotypes, and if you're interested, read the paper. You have much more detail. But for instance, you have an obese patient entering. They have very unique pathophysiology. Oxidative stress, systemic inflammation, insulinoresistant, chronic pelvic ischemia. Next slide. And the best treatment probably for an obese patient with OAB is weight loss. It seems stupid, but it's the truth. We have this, again, this New England Journal of Medicine. We often say we don't have evidence in functional urology. And you see, we have quite a bit of New England Journal of Medicine randomized trial. So if we work all together, we can build evidence and we can do evidence-based medicine. That was a quick message, but in this program, in this randomized trial, a weight loss program did improve significantly urgency incontinence and stress incontinence in obese patients. Next slide. And bariatric surgery, obesity surgery can be an option as well. You can have an amplitude of effect that is huge. So those obese patients, probably giving them pill, maybe not the best option. Next slide. And I could go on and on with the phenotypes. We have data showing that probably phosphodiesterase inhibitors works better in obese, but I won't go into details. Next slide. Even in female, same. I won't go into details on this. Next slide. Sorry, Roger, to give you orders, but I have no choice. Cystocele can be helpful. Same, that's another phenotype. It can be helpful, I mean, to identify the cystocele because, next slide. If you often have OAB and prolapse and DO and prolapse. Next slide. And if you treat the prolapse, basically it works. You have 60% of those patients being cured. You have this one, very complex, the uretrogenic. Yes, that's the proof of concept. Next slide. Yes, we can skip because I will go over time and I don't want to lose my two friends, Arun and Arun no, and Eskinder, and I don't want that Roger fire me from the ICS. So next slide. It's not the most interesting. Duloxetine can be helpful. Next slide. Especially if you have low maximum ventricular pressure, we can skip that one. Anticholinergic burden, of course, influence what you want to do. If you have a patient with high anticholinergic load, of course you want to avoid anticholinergic, you increase the risk of dementia and you decrease the chance of efficacy. This is purely clinical for now. Next slide. Underactive bladder, that's an interesting one of the phenotypes. I don't know who said that sentence first, but bladder is an unreliable witness. And so the symptoms described by the patient, and it's the whole concept of what we're discussing tonight. What the patient described does not mean and cannot tell you the underlying mechanism. And so when you have underactive bladder, next slide, and detrusor underactivity, guess what? The symptoms that are the most frequent are OAB symptoms. Exactly the opposite that what we would think. This is from the Paul Abrams group in Bristol. They looked at all the detrusor underactivity patients they had, and they observed that the vast majority of symptoms they had were OAB. So OAB can be underpinned by detrusor underactivity. If you don't do a urodynamic to understand that, I don't know. And again, I don't want to steal the talks of my friends, but I think that can be helpful to to detect that. PVR is helpful to detect that they have incomplete bladder emptying. Next slide. Just do it, meaning I love to do PVR. I think it's a very simple tool and it helps you to screen if there is a voiding problem. If there is a voiding problem, even on uroflowmetry and on free uroflowmetry, then probably moving to further test, that would be fantastic. And maybe the further test could be called urodynamic. And those bladder emptying problems, they help me very much to determine if I prefer to go for botulinum toxin or sacral neuromodulation when we go for third line treatment. Next slide, and I'm almost done, I think. Sorry for being late. This one we can skip. Some patients have coexisting OAB, and you can keep going because there is a lot of animation on that one. So keep going. Those are all the treatment options for bladder pain because OAB and bladder pain, they often coexist. Nocturia, we can skip, we don't care. So you can skip the next Yeah, this one you can skip. It's even in French, so we don't care too much. We can skip that one too. And that one too. And that one too. But you can have my slides and you can read them and reach out to me if you have questions. Next slide. I always do too many slides, plus the problems that I had today. That was too much. Next slide. And it's a conclusion. So in conclusion, 5 last slides and then I shut my mouth. We are at the time of patient-centered approach, shared decision making. To do shared decision making, you have to document what's going on and you have to give all the arguments to your patients. The advantages of each therapy, the drawbacks, but also why one therapy would work better depending on the pathophysiology. Next slide. So this is my vision of shared decision making, and I want to thank Arun and all other UK friends who are not here because you taught me shared decision making and patient-centered approach, and I think UK colleagues and UK physicians, you are way ahead of everybody else on that, and I think it's super important to discuss with the patient, but to discuss with your patients, especially if he is an engineer or something, they want to understand. If you have documented things with a urodynamic, you can discuss that much better with them. Next slide. You can go to the next slide. I won't go too deep into the shared decision making. So in the end, I think OAB is much more complex than one we want to think. It's much more complex than just, oh, urgency, anticholinergic doesn't work. Let's go to the next slide, blah, blah, blah. Next slide. This algorithm to me, you can go to the next slide, is dead. We should not go stepwise. And for the first time, the AUA guidelines published this year the first non-step OAB guidelines. And we'll push, I'm part of the EAU guidelines, as you know, and the next ICI is also on his way. I really will push, I know, with my friends, Arun, Eskinder, and many others, maybe that are online, we have to push to go away from the stepwise approach. The armamentarium is huge. It's not restricted to what we were told. Look, all of these are OAB treatment. So to find the right way to treat those patients, we need help. Next slide. Don't be blind by the terms HAV is in French. It means OAB. The terms OAB can blind you. Next slide. So you have to phenotype and you have diagnostic tests, and maybe Arun and Eskinder will tell us about a good diagnostic test to phenotype. Next slide. Next slide. And next slide. And sorry for having been late and for all the mess. Thank you, guys.
Brilliant. Thanks, Benoit. Absolutely brilliant. Don't worry about the technicalities at the beginning. So I really hope that if you haven't, I put it in the chat, and I'm not just saying this because these are my co-colleagues. The review article that Benoit authored in the European Urology is an absolute must-read for anybody interested in the subject. It really puts into context, I think, how heterogeneous OAB symptoms can be. And I think Benoit has very eloquently demonstrated that with all the multiple phenotypes he's shown. But it's really nicely summarized in his review article, and I encourage you all to read it. I think in the interest of time now, we will swiftly move on to Eskinder's talk about the utility of urodynamics or not. And then we will quickly go on to the future trial, and we will take all the questions in one go at the end. Eskinder.
Hello, everyone. I would like to first thank the ICS for putting together such an incredible masterclass. This is obviously a very topical masterclass, and I'm glad we get to run it. So I am Eskinder Solomon. I'm a clinical scientist. I work at both Guy's Hospital and Evelina Children's Hospital. These are pediatric and adult high-volume urodynamics tertiary referral central London hospitals. So for me, working in these departments, the value of urodynamics is clear. But however, in the last 5 years or so, the PR of urodynamics has come under attack. So we've taken hit after hit. There's been the value trial, as I'm sure you're aware of, the upstream and now future. And each of those RCTs have questioned the clinical utility of urodynamics. And the skeptics have now joined in. They've been screaming boo at the entrance of every functional urology department. However, the joke's on them because boo is a urodynamic diagnosis. So, in an attempt to look at this from the skeptic's perspective, I've had to stand back and really ask myself, what is the value of urodynamics in female OAB? Do we not value it because we don't value the need for objective diagnosis? Do we not value it because we don't think urodynamics can make objective diagnosis in this context? Or are we not aware of all of the prognostic parameters urodynamics can tell us, both in terms of guiding management as well as perhaps giving us an indication or a likelihood of success or perhaps complications? So let's unpack all of these one by one. First, why do we need objective diagnosis? I think Benoit has rather eloquently described just how complex OAB can be. And in fact, he made reference to the quote I would like to draw your attention to, perhaps the most widely known quote within functional urology. This is from Turner Warwick, and he said, famously, the bladder is an unreliable witness. And the reason, or what this saying is implying, is a patient's symptoms do not reliably reflect what their bladder actual pathophysiology or physiology is. And multiple conditions can produce the same symptoms. Therefore, we need objective diagnosis. And if you need a more up-to-date reference, I would recommend you watch this video, which is titled Urodynamics Under the Lens. It's an ICS video, and it's got very highly respected urologists from all across Europe emphasizing the importance of objective diagnosis. Here's Professor Marcus Drake giving us his take in his own emphatic, eccentric British way.
I find this question extraordinary. Objective diagnosis is the absolute foundation of sensible decision-making in a clinical context. Get that diagnosis properly in place, and then you can be rational.
So now that hopefully I've convinced you that we need objective diagnosis, let's explore whether urodynamics can do it. Since its inception in 1896, I believe, urodynamics has been really well documented and is well studied that its ability to be able to fully characterize filling phase and voiding phase bladder and urethral function. We can use urodynamics to fully understand the lower urinary tract dysfunction. We can document the presence of DO. We can characterize the DO in terms of amplitude, onset volume, whether it's associated with incontinence, reflux, and so on, whether there's poor compliance, obviously sensation, whether it's increased or is associated with a DO, it's just hypersensitivity, what the cystometric capacity is. And as Benoit mentioned, the voiding phase, even in patients who complain of overactivity, is incredibly important, in the presence of bladder outlet obstruction or detrusor underactivity, and the post-void residual and the voiding efficiency are all very key parameters that we use to understand the connection between the lower urinary tract symptom and the lower urinary tract dysfunction. And it's that allows you to direct management. And if I could just draw your attention to just 4 patients that I've seen in the last 2 weeks, all presenting in exactly the same way, i.e. OAB. And if you look at their urodynamics, they're incredibly different. First patient has a small capacity bladder. She has demonstrated a very high pressure DO that has then resulted in urgency, and we've allowed her to void, and you can see she's got decent voiding with complete emptying. The second patient, again, presenting identically, but it's got phasic DO with, again, very high pressure DO, but this time associated with quite significant functional obstruction with very high pressure voiding and very low flow. The third patient, small, low amplitude DOs, but normal capacity, and again, obstructed voiding, and with a significant cystocele. Interestingly, the clinical exam beforehand mentioned only a very mild or moderate cystocele. And finally, a patient who's had standard urodynamics, but that was diagnostic in their referring hospital and was referred for ambulatory urodynamics. And despite having spent 6 hours with us and about 10 voids during that period, absolutely no evidence of detrusor overactivity. So you can see all 4 patients presenting in exactly the same way, with the same level of bothersome level. However, we need to ask ourselves, should these patients treated only by the symptoms, should they have the same treatment, and also do they have the same likelihood of success or complication from the various interventions that we might perform as a second line option? So this takes us to the next aspect that urodynamics can offer you, and that's prognosis or prognostic parameters that can tell us whether an intervention is likely to work or direct us towards neuromodulation or Botox. And I think Benoit touched on this too. So parameters of interest to us are, again, as I mentioned, DO, compliance capacity, the bladder contractility, and whether there is some outflow obstruction, and whether obviously there is stress incontinence or pelvic organ prolapse. And in terms of just talking through the rationale, why it might sway you to think about Botox in one patient and perhaps a neuromodulation in another, is really thinking about the mechanism of action of these treatment options, whereas Botox typically paralyzes the muscles, suppresses the DO, whereas neuromodulation is thought of as being one that modulates sensation. We really should match the urodynamic finding to what is likely to be optimal management. And optimal management is one that suppresses this pressure, while at the same time minimizing complications such as the need to self-catheterize. So if you look at all of these studies which have combined and have looked at the predictive power of urodynamics in terms of whether botulinum toxin or sacral neuromodulation is a good option, you can see Botox typically does a much better job at suppressing the DO amplitude, whereas neuromodulation, very modest suppression, and if that, it happens only occasionally, and Botox has a much higher chance of suppressing DO. So if the effect we're trying to achieve is a suppression of the overactive contraction, really it should be Botox that we're thinking of. And perhaps if we're thinking about just suppressing sensation, then perhaps neuromodulation is an option. And perhaps neuromodulation is something we might want to cautiously approach or maybe not consider if patients have very high pressure, because the last thing we want is suppress their sensation and allow the motor effect of this dysfunction to persist. And again, Benoit touched on this shared decision making, but part of that is also making sure patients are fully informed when they consent for their treatment. We need to make them aware of how certain we are of their diagnosis, and whether, if we have an approach to ascertain the likelihood of success or complication of an intervention that we're putting them forward, and we don't do that test, are we perhaps not fully informing them? So therefore they're not taking, all of the information that they should have when they're choosing a treatment option. And perhaps if we don't do that, are we also exposing ourselves medical legally? So to summarize my thoughts, essentially the clinical utility of urodynamics in female OAB is, one, to fully characterize the lower urinary tract dysfunction and explain the symptom and make an objective diagnosis for why the patient is presenting the way they are. And in addition to that, we can also derive prognostic factors, which allows us to optimally direct management as well as consent these patients. What I would like to leave you with my favorite Chinese proverb, and that says, to act without knowledge is to wield a sword in the darkness, and to act with knowledge is to strike with precision of a master. Thank you.
Brilliant. Thank you so much, Eskinder. I'm going to... Brilliantly done. And I think this will follow on nicely. I'm going to give my talk now, and we'll do the questions at the end. Like I said, I've just put something in the post, so feel free to post any questions you have, and we'll leave at least 10 minutes for full discussion at the end. Thanks so much. I'm going to share my screen now. Fantastic. So like I said at the start, I'm Arun. I'm one of the urologists at Guy's, and I'm going to talk to you about this extremely important bit of research that was carried out called a future trial, and hence the title of our webinar, slight pun intended, when we said, what is the future of urodynamics? Because it was alluding partly, of course, to this trial, the future trial. Just quick conflicts of interest for me. I have a number of company disclosures related to refractory overactive bladder treatments, but actually, and more importantly for this talk, is that Guy's Hospital, where I work and where Eskinder works, was actually one of the centers. I was the local PI for this trial. So this is the future study. It's a UK-only study, multi-center, run by Mohammed Abdul Fateh and Christopher Chappell. And we really must congratulate all the authors of this trial in getting it achieved, or getting it over the line, only because so many centers were involved. It was quite a difficult study to get done, and the COVID pandemic happened in the middle of it. So kudos to everyone involved for the study, but we will talk about the outcome of it and the potential controversies that has resulted. It certainly had a lot of discussion since the trial was published, and it has been published in The Lancet, as we all know, one of the best journals in the world. So this was 63 centers, hence a huge study. It was a superiority trial, which is interesting. A lot of trials these days are inferiority. This was a superiority trial, parallel open label, and the recruitment was for refractory overactive bladder or refractory mixed incontinence, but it had to be urge predominant. As with many of these studies, they had to have failed what we call conservative treatments or pharmacotherapy, and it was one-to-one randomization. And this is the key bit. It was to what they call in America office evaluation, and here they've labeled as comprehensive clinical assessment on one arm versus the same comprehensive clinical assessment and urodynamics. So it was powered, like I said, to detect a minimum of a 10% superiority of the urodynamics arm compared to just the office-based assessment, and the success rate assumption was around 60% for the secondary treatments the treatments for the refractory OAB. So 90% power of 5% level of significance, needed 986 participants. They know with all these studies there'll be an attrition rate. And so in fact, they actually randomized 550 into the urodynamics arm and 549 into the office-based assessment arm. A typical exclusion criteria for these kind of overactive bladder trials. So you can see here where I've circled the list: predominant stress incontinence out of the mixed, if they'd had urodynamics within 12 months, if they've already been treated with Botox or neuromodulation, neurogenic bladders were out, bladder pain was out, recurrent chronic cystitis and UTIs were out, and radiation bladders were out, and of course fistulae and planned pregnancy. So this is actually not in the paper. This I've had to fetch out from the appendices of the study, but this is essentially the trial design, that following on from the assessment or assessment plus urodynamics, patients had to be given one of three diagnoses: either OAB or mixed incontinence, predominant stress incontinence, or other, and those then were screened out into be offered tailored treatments for stress incontinence or other things. And the group that were interested in the OAB or urgency predominant MUI were given refractory OAB. If they had urodynamics, of course, that translated into having detrusor overactivity, or what we call predominant MUI, which was detrusor overactivity and urodynamic stress incontinence, but with the predominance for OAB symptoms. And then you can see they were offered secondary line measures, and we'll come to that. Of interest, which I've circled in the bottom left here, is that the study group reviewed 20%. So not all the urodynamics, 20% of the urodynamics were reviewed by the expert committee. So this was all a PROMS-based outcome measure. That what they used in this is the primary outcome was the PGI score, which is the patient global impression of improvement. They had a strict criteria, which was very much or much improved as their definition of success as the primary endpoint. Now, as the secondary endpoint, they had a less strict criteria, which included very much, much improved, or just improved. And then there was a whole plethora of other PROMs, such as ICIQ, OAB, urgency perception, bladder diary, FLUTS, ICIQ, LUTS qual, and EQ5D, which is actually a critical bit for the cost effectiveness. Complications were also assessed, and a whole load of cost effectiveness measures. This is a very busy slide, but essentially it tells you that the two groups had very equivalent baseline parameters of the usual things we would look for: mean age, BMI, parity, previous surgeries, what kind of pills and pharmacotherapy they had before, and importantly, the baseline PROM scores were equivocal. So what did they go on to have in this study? Well, the majority, and I mean the vast majority, ended up having Botox injections. Actually, the extreme minority had sacral neuromodulation. So very little patients had sacral neuromodulation. Very few had PTNS. Some actually went to physiotherapy. And you just wonder whether that was the group who had stress or predominant stress after the screening. And others had catheters. Very few had antibiotics. But the vast majority were botulinum toxin. So what about the results? This is the key bit of information. Now, these PROMs I was telling you about, the PGI-I, the endpoint was based on that PROM at last known follow-up. Now, in the original study design, this was due to be at 15 months. But as I mentioned, the COVID pandemic happened, and therefore they had to have an extended PROM, which was granted by the ethics committee at 24 months. So this is not in sync with necessarily when the treatments may have happened, just in that pathway. Once they come in the trial, they get the PROMs at specific time points. Now, what the last known PROM showed is that if you looked at urodynamics and office-based assessment, the success at last known follow-up was 23.6% by the strict criteria. Now, if you look at the office-based management alone, the success was 22.7% at the last known follow-up. So when they analyze this statistically, I think we can obviously see there was no statistically significant difference between the two groups. Now, even if we use the less strict criteria, the success rates do go higher, as predicted, 43.8% in the urodynamics arm versus 41.6% in the office arm, but again, statistically no difference. Then they tried to analyze this not only by just the pure group that were recurrent overactive bladder, which was 2/3 of the population, but the other 1/3 were urge predominant mixed incontinence. Even if you analyze these two separately, the primary endpoint outcome was exactly the same. When we looked at the other PROMs, I told you there was a huge other amount of PROMs collected for the secondary endpoints. Again, very similar outcomes with those in both arms. And importantly, they did assess the Botox effect 2 months after whenever the Botox was given. And the success rates were 63% in the urodynamics arm versus 60% in the office-based arm, again, with no statistically differences statistically. Adverse events I won't dwell on, but the usual things with these kind of therapies, as botulinum toxin was the most common effect, we saw a reasonably higher than expected rate of UTIs, 7% in both arms. And the whole list is here. I'm sure the talks will be shared at the end. What about the information we got from urodynamics? This is important to understand, and I'm sure my colleagues will talk about this in a second. So in the urodynamics arm, 58% had detrusor overactivity. Interestingly, despite the entry criteria being OAB and in mixed incontinence, 13% had pure urodynamic stress incontinence. 8% had what we call urodynamics mixed incontinence, which is evidence of detrusor overactivity and urodynamic stress incontinence. And even more interestingly, I thought, 21% had neither DO or urodynamic stress incontinence. I mentioned earlier 20% of the urodynamics were reviewed. Interestingly, 4% of that group, they didn't agree with the center's interpretation, and that was fed back to the unit and then changed. What about the cost? In summary here, I won't dwell on this too much. In the NHS system here in the UK, cost effectiveness ratio would be less than £20,000. And unfortunately, in the urodynamics arm, the initial figures they got was 42,643 for urodynamics, with a 34% chance of it being cost effective. Once a bit of further modeling was done, in fact, this number went down to 29%. So the conclusion from this study is that adding urodynamics into this wasn't a cost-effective maneuver. So in summary, it is extraordinary that they were able to complete this study. And like I said, I think the authors should be congratulated for that. Superiority of urodynamics was not shown in this study, and it was not shown to be cost-effective. Botox was the commonest treatment. There was a very low uptake of neuromodulation. which I think actually is due to the NICE guidelines in this country, because that's what clinicians tend to offer. And certainly in the old guidelines, botulinum toxin was put at the front of that, and neuromodulation was only offered if they couldn't do CISC, for example. And I think that might have skewed a lot of the data that way. Interestingly, this for those of you who know about the VALUE trial, which is a very similar design style, but for stress incontinence, there were similar outcomes in this. But there were certainly limitations to the VALUE trial. And the real question is, are there limitations to this trial? And we can go on to that now. Thanks for your attention. Right. Team, other team here, Eskinder and Benoit.
Of course.
Brilliant. So lots to discuss. Why don't we kick off with some discussion, and then we will pick up some questions from the chat. So let's start. What do we think then about the future trial and its results? Huge impact trial from the Lancet. What's the general thoughts?
As you can imagine, this is something I'm fairly passionate about, so I have made a list. All right.
Okay.
So the first one is a conceptual problem. I think we're testing effectively the outcome differences of an intervention using a diagnostic test, and then we're judging the clinical utility of it. So really, that is conceptually flawed. Like, you can't really assess the effective clinical utility or the diagnostic accuracy of a diagnosis test using an outcome of an intervention, because there's of course so many confounding factors that affect it. The second is all they use the urodynamics for, as far as I could tell, is to look for absence or presence of DO. And as I mentioned in my talk, actually the more prognostic factors are almost everything else, in addition to characterizing the DO itself. So I think that's quite an important point. And interestingly, actually, when the trial protocol was first published, it emphasized the use of routine urodynamics in OAB. However, that word routine dropped off, and now effectively the conclusion seems to be a blanket statement that urodynamics doesn't seem to offer a clinical benefit in female with OAB. And as I've mentioned, even just in the examples that I've shown, clearly you can see these patients will symptomatically present almost identically, but once you do a test, which obviously fully allows you to understand the lower urinary tract dysfunction, you can tailor their treatment. And I just can't see how many could argue about the clinical benefit of that. Where, of course, it gets murky is at what point you say select cases and everyone. But clearly, in a majority of the patients who present to our hospital, it's very difficult when you look at the urodynamic test to not justify having the test. Because of all of the information it unmasks, which directly affects which kind of management they have. So I think that's another key point. And the other is, of course, the urodynamic parameters were not used to direct patients to either Botox or neuromodulation, because about 85% had Botox. And a final point is, what was actually most helpful from the upstream trial was the sub-analysis of the urodynamic parameters they did in identification of all the prognostic factors. Because what that found was BCI and the bladder outlet obstruction index were key prognostic factors, one increasing the likelihood of a positive outcome and one increasing the likelihood of not having a benefit. So if a test, which you do not do, could have told you whether you're likely to benefit from an intervention or you're likely to have an intervention complication, is that really a helpful, individualized approach to how we should be managing our patients, or should we be just using population statistics as the future trial recommends?
Right. Benoit, so I will ask you something very similar. Do you think we need to have a urodynamic diagnosis for our patients then?
Of course, I think I would agree I don't know if we have the poll in the end, but I would
We will do that. We are going to do that.
I would agree 100% with those who said, so 0% who said never. I think that would be the worst message that you could take from this trial. And the second thing is, of course, I would, in France, there is this saying, I will say it in French and I'll try to translate. It says, En médecine comme en amour, ni jamais ni toujours. In medicine, like in love, never, 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 ever. So of course I would not do urodynamic to all of my patients, but of course I would never use this trial with all this flow to say never. I can skip urodynamic forever. And there is so many flow in this trial, and I think you know that I'm a speaking person, so please stop me when you're bored. But we just doing a little teasing. We did a reply to the Lancet with Eskinder. We did a reply to European Urology, and I will announce a scoop. We're preparing a full paper to criticize that paper. I don't know it has been much done in history. That will be published in the World Journal of Urology. I'm the one to blame. I'm just reviewing it, but it will be released soon. And as you are an editor, Arun, I hope you will accept it. But anyway, no, but because there is so many flow, and I think more globally, I love evidence-based medicine. We are in the era of evidence-based medicine. We need to build more robust evidence. I said it in my own talk. But the issue with evidence-based medicine is that it's not everything. It has to be done cleverly. And you can have very wrong message if you don't do it properly. I don't have my slide here, and I won't try because, again, that would be a mess. But you know the parachute message. If you randomize three people to two groups, three jumping without a parachute and three jumping with a parachute, there is no statistically significant difference. But three of those people are died. So sometimes we also use our brain, right? And here to name a few, but again, I have a list like more than my Christmas list of flaws for this trial. But one of the worst to me, if I have to pick one, is the pressure flow study in that trial was presumably done, but we have zero data on it. And I always tell in my talks that to me, the most useful phase, and we said that during this webinar, the most useful phase, even in a female patient, is a pressure flow study. Because Tamzin and her group, and a guy that you may know, Arun, named Sachin Malde, published a fantastic paper in LUTS 2019, and you give me publicity, I will give publicity to Sachin, your colleague. You should read that paper about over 1,000 female patients going to clinics with any LUTS having video urodynamics. 19% of them were obstructed. It's not because you don't have prostate that you cannot be obstructed. And of course, treating obstructed female OAB patients with anticholinergics or Botox is completely dumb. And those 19% of female OAB patients, their most common symptoms, as I said, were OAB symptoms. Bladder is an unreliable witness. We have repeated that enough. So I will stop because otherwise we'll be there tomorrow morning, but that's a few thoughts about that trial.
Very well put. In fact, you stole exactly what I was going to say about that. So not only Sachin, but of course, Eskinder is responsible for the Solomon Greenwell nomogram about female bladder outflow obstruction. But interestingly, those patients, like you quite rightly say, 2/3 will present with frequency and urgency. Another one of the phenotypes potentially of OAB, but actually it's a voiding dysfunction problem. So my quick views on this, I agree with my colleagues and I echo their comments. The lack of the voiding data is a big issue. Now, obviously, this trial is only in women, and we have a hugely undiagnosed population of females with voiding dysfunction who may present with storage LUTS. So that is an excellent point Benoit raises. But there's additional things that urodynamics bring to the table. Not only will we phenotype. I've seen someone's put a question in the chat box about those without DO, have they got sensory urgency? Now, it depends how we want to manage that. I have very strong views on how those are managed, but certainly if they were refractory, I may be pushing those patients more into stimulation as opposed to other treatments. My own personal experience, actually, despite other papers, I'm talking about my own personal experience, is that Botox in that group is actually not as good as the group if you have a genuine overactive bladder. So I think it's not quite as clear cut as value, which is about stress, because what we've worked out, the value trial was applicable to about 5% of women that present to urology units with pure monosynaptic stress incontinence. We could argue at least one advantage, I think, is that if you had a pure OAB wet patient, with no other issues like at all, so no stress, no this, no that, then we may all agree potentially that patient may be able to go through the system, I think, without having a urodynamic study, maybe. But that is if you don't want to offer maximum information to the patient. And we go back to shared decision making. If I spoke to a patient and said, would you want me to get the most information I can to make the best treatment options for you? Would you want this? 99% of my patients would say yes, because we will diagnose other types of incontinence. We will diagnose voiding dysfunction. We haven't talked about men yet, but we did briefly touch on that with upstreams. In men, as we all know, OAB can be a secondary phenomenon to outflow obstruction because of prostate, and then counseling about all this makes a huge difference. So for me, the counseling I can give the patient will be inherently better if we had done urodynamics. But like we said, it goes back to shared decision making. I'm so glad, Benoit, you mentioned earlier about this and emphasized this so much. And it is groundbreaking to see the AUA leading the way in that regard with the OAB guideline. We will go to the chat now, if you don't mind, and just answer off these questions that are coming through. Let me have a quick look. I think there was a question, Benoit, to you about your views on tibial nerve stimulation. That might be the implant, I think, on OAB. Any thoughts on this, please? Generally, I think this is more about OAB treatment as opposed to utility.
I try to reply as much as those questions directly to the people asking. So I have replied to that gentleman, but I would just say very quickly that I think the place of this will keep growing. If you ask me, my very deep feeling about that is that percutaneous will die. I don't know if it's done again in the UK, but it will die. Too invasive, you have to go, it's too burdensome for the patient, you have to go to the office, blah, blah, blah. Transcutaneous is used for 20 years in France, home-based. I know it's used more and more in the UK. It works quite well, and the patients loves it because it's very natural, let's say, non-invasive, blah, blah, blah. Implantable has started very fast in the US, and implantable tibial, I think, will grow too, and we will have many different implantable tibial coming, and I will do two teasing. First, we will have so come to the EAU in the fantastic city of London, where you can meet wonderful people like Eskinder and Arun, but I'll be there too. And we will have a plenary session on who will win the battle of neuromodulation, because there is a lot going on in neuromodulation: sacral, tibial implantable, tibial transcutaneous. There is even something that you may know, Arun and Eskinder, called peyroneal stimulation from Jan Krut. I cannot be objective. This is my favorite because I'm Benoit Peyronnet. So the peyroneal stimulation, I quite like it anyway. But there is even transcranial, there is vagal, so we will have this, and we will have a special issue in the World Journal as well, specifically on that topic.
Brilliant, thank you. A couple of more quick questions coming through here. This is a really interesting question. Eskinder, I'm going to put this to you. I think this is right up your street. Question here is, in most low resource countries like Africa, we do not have urodynamic machines due to the cost of procurement. How would you advise managing patients like this in such situations? Excellent question.
So, excellent question indeed. And I have done a lot of teaching in low resource centers, and it used to break my heart when I would go there and, everyone buys into the clinical utility of urodynamics, but they were unable to afford it. As a result, we've come back together with a group of clinical engineers from the UK, and we put together a urodynamic system for less than $99. I will put the details of the website from which you can procure this urodynamic system in the chat. But I'm hoping, at least in the future, that not being able to afford the urodynamic system will not be a reason why patients do not get urodynamics everywhere in the world.
Wow. Yes, that is unbelievable. $99, was it?
That's exactly the cost. Maybe even cheaper if you bulk buy.
Okay. But I think going back to what I mentioned, I think if you can phenotype as best you can, so that means a lot of exclusions, and you have a pure OAB wet patient. I don't think it was any other distractors, red flags, other things. Then I don't think it would be unreasonable, especially in that environment. Something here about very good question again. What about which is part of the office-based assessment, by the way, in the future trial? What about free flow uroflowometry and PVR? I think the question really is, well, we would have got some indication about voiding problems just from the free flow. But I think that would have needed, I think, then for us to do something different in the trial. And I think the trial design was such that I think if we did see some of these minor issues, I'm not sure if that translated actually into differentiating treatments. But any thoughts on free flow?
Yeah, just to counter that, actually, the two case studies that I used in my talk were all patients with relatively small voided volumes because they have functionally small capacities, as most OAB patients do. And therefore, you often do not get a decent enough void to be sure just from a flow rate and PVR. Yes, of course, if there is a huge PVR, yes. But if they're obstructed or have a degree of DU, it typically is difficult to see it from the small volume voids you might get in a lot of patients with OAB.
Fully agree. Okay, gentlemen, it's 6:10. I think we could talk, as Benoit said, probably for another 3 hours. I know certainly that would be possible. But unfortunately, we do not have that luxury now. Please feel free to share this with colleagues. I'm sure the discussions about this study and in general the utility of urodynamics will come on. And we look forward to some of the publications that are coming out that I'm sure will encourage more debate. Thank you so much, really, now to the ICS for putting this on. Thank you to my two wonderful colleagues who presented so eloquently and contributed to the discussion. Thank you as well for posting some questions. But before we go, the final thing we will do is put the poll back for whoever's left on the webinar. Okay, Roger, do we have the result?
I want the results.
Great.
Benoit, you'll be happy.
Nice.
We're still
Nice.
0% on never. So I think now
What
we are
would be
moved.
your answer, Arun?
Your
Mine would be between 2 and 3.
Yeah, I think the guidance is changing slightly, but I think I'm more practical now. But I am still urodynamics heavy, I would say. Let's put it that way. So I'm leaning into most patients. There are, of course, some men that I'm more less likely to do it in men, but in certain age groups, like less than 50 or 80, I'm definitely doing urodynamics in men. And in selected patients. In women, to be honest, I'm doing a lot. But I'm spoiled, right? I have to be honest. I'm very spoiled. I have Eskinder working with me. We have the luxury of very advanced diagnostic testing. And when I have that next to me, I'm almost crazy not to utilize it. But that is not the case for everyone. And I fully appreciate everyone's unit is different. They may not have access to video and all these other things that can be helpful.
Good answer. If I had Eskinder, I would put number 1 in every patient, but I don't have him.
But
I know Eskinder's answer, so we won't ask him.
No, no, no.
He
I
is in
think you
every
should ask
patient.
me. No, no, no. Because just like you, I work with many urologists, and I think in functional urology, which is almost seems to be the exceptional specialty, is we accept lack of resources as a clinical excuse not to do a test we believe clinically has value. And you wouldn't have that in any other field. If they truly believe a test is required, they will not use lack of resources, obviously barring, developing world, as a reason why they wouldn't do it. What they would say is this is an absolutely essential part of my clinical decision making, and they would aim to secure that funding. And I think in functional urology, we very quickly defer to I don't have it rather than I need it. and no one will give you if you say you don't need it.
Okay, gentlemen, we'll bring it to a close. Thank you all for joining. Have a good night.
Thank you all. Bye.
Bye, everyone.